We'll be getting started shortly. Please share your name and where you are joining us from in the chat box. Welcome, everyone. Thank you for joining today's webinar, Barriers and Successful Strategies for Engaging Rural Populations in State Comprehensive Cancer Control Planning, Program Manager Perspectives. My name is Abby Nellis, and I am an associate with CACA's Geographic Health Equity Alliance, or GEA for short. GEA, in partnership with the University of Iowa's Advancing Cancer and Rural Equity Lab, is excited to present today's webinar on how we can improve inclusion of rural needs in state comprehensive cancer control plans to directly address rural cancer health disparities. GEA is a CDC-funded national network dedicated to reducing geographic health disparities related to commercial tobacco and cancer. GEA provides free training and support to start tobacco and cancer control programs and their partners on how to reduce health disparities and improve the health of communities across our nation. We encourage you to visit our website, geohealthequity.org, to learn more and subscribe to our monthly newsletter. Next slide, Whitney. I'm sure we are all familiar with Zoom by now, but I'd like to go over a few housekeeping notes. All participants are muted by default, so for general comments, please use the chat box. We will have a Q&A portion at the end of the presentation, so for any specific questions for the presenter, please use the Q&A box. This week, you will receive a post-webinar email with the recording of the webinar, slides, and an evaluation survey. We kindly ask you to fill out the survey. Letters of attendance are given only upon completion of the evaluation survey. Next slide. And now I'd like to introduce our presenter, Dr. Whitney Zahn. Dr. Whitney Zahn is an assistant professor at the University of Iowa's Department of Health Management and Policy and is a full member of the Holding Comprehensive Cancer Center. Her research employs health services research, social, epidemiological, and spatial methods to address rural cancer disparities across the cancer continuum and to evaluate access to healthcare services. She has a particular interest in reducing cancer disparities among rural minority populations. She leads the university's Advancing Cancer and Rural Equity Lab. Dr. Zahn also serves on the board of the Iowa Rural Health Association and co-chairs the Cancer Prevention and Control Research Network Rural Cancer Work Group. Dr. Zahn, I will pass it over to you now.
Great, thank you very much, Abby, and thank you all for being here today. Just note to pass along to Abby and Daryl, looks like the chat is disabled, so folks are putting in some comments into the Q&A, just more as an FYI from a Zoom management perspective, just to let you know, but we'd love to hear where you're from, either in the Q&A box or the chat if that's able to be enabled. So go back just to hear the title slide. Thank you very much all for being here. It's great to see such a large group of folks joining for this discussion. And thank you again, Abby, for the introduction and for arranging this webinar here today. And I look forward to sharing some barriers and successful strategies to engaging rural populations in the comprehensive cancer control planning process, and sharing some perspectives from program managers. Maybe some of you we had the opportunity to be connected with as part of this study and this analysis, and we're really excited to share what we found back to those who are involved in these planning processes within your states, and hopefully this information can be helpful for you to continue to do your great work, and so we're just really grateful to be able to share this. And I'll note that I'm sharing this in part on behalf of our Cancer Prevention Control Research Network, CPCRN, Rural Cancer Work Group. As Abby noted, I am the chair of that work group, and this is some work that we have done collectively as a larger group over the past couple of years that I'm excited to share back with you. And I'll apologize in advance. I'm getting over a little bit of a old school non-COVID cold, so that might come across in my voice or uh, throughout this presentation. So I'll give you a heads up on that, and hopefully it'll hold up here today. So just to give a little bit of background to our group who did the work that I'm about to share, we are a CDC-funded network of institutions throughout the country who also have CDC-funded prevention research centers. And our network's goal is our vision rather, is to reduce the burden of cancer in U.S. populations and eliminate cancer disparities. And our mission is outlined below here, focused on accelerating the adoption and implementation of evidence-based strategies in communities, try to strengthen and enhance large-scale efforts to reach underserved populations and reduce the burden of cancer, to understand processes to achieve the aforementioned goals, and also to develop the dissemination implementation workforce in cancer prevention and control. So really focused on trying to implement evidence-based practices, particularly for populations who are disproportionately affected by cancer, and that includes rural populations. So we have several work groups and interest groups focused on a variety of areas, including one focused on rural cancer that has been active since 2018. And so we've done work in a variety of areas, and I'm going to share a little bit of some of this that's related to this very important topic of comprehensive cancer control planning. So my objectives here for today is to describe how rural perspectives have been included in the comprehensive cancer control planning process, and also to identify barriers to and strategies to including rural perspectives in these planning processes. So sharing back to you all as people who are working, boots on the ground with communities, with your states, with your coalitions, with your state comprehensive cancer control programs, either working with them or as part of them to address these, what we have found for folks who've been really engaged in this process as effective ways, barriers or effective ways to engage rural communities. So I just want to share why is this important? So this is a slide that I use very commonly in anything I talk about when it comes to rural cancer disparities. I think just a reminder to us as to why these are particularly important. So depending on the definition of rural we use, and we know that emerged actually from our interviews, is that there's many definitions of rural, but regardless of which ones you use, we know that there are 15 to 20% of the U.S. population who live in rural areas. So that runs upwards of 63 million Americans throughout the country. And so while we think about rural as being a smaller population group, more isolated population group, it still is a lot. There are a lot of people living in this, and this is going to vary state to state. There are some states where this is upwards of 40 to 50% of the U.S. of your state's population. So I'm sitting here in Iowa, and 40% of our population lives in rural counties. So this is going to vary state to state, but it's important to recognize just that aspect of our overall population. And we also want to emphasize as well that rural populations are not a monolith. And the percentage of rural populations that are people of color is growing. It's now at 24% of our rural population are non-white. We're seeing particular growth in the percentage of people in rural America who are Hispanic, Latino, and so it's important to recognize that aspect of who rural populations are as well. We also know, in thinking about cancer disparities, think about any kind of health disparity, the sociodemographic characteristics that play a role in that. So again, these are generalizations. We know every community is different, but in general, rural populations do tend to be older and poor, which can contribute to greater cancer disparities, regardless of where we live. As we get older, we have a greater risk for cancer. And so that plays a role in this. And also, we know that lack of access to care, costs of care can contribute to to cancer disparities, and being less affluent can play a role in that. And so we see rural populations as well tend to have more prevalent, for lack of a better term, I need, still searching for the most appropriate way to put this, but more prevalent risky health behaviors, so higher rates of smoking, lower rates of HPV vaccination, less physical activity, those kinds of things tend to be more prevalent in rural populations. This is true of populations overall, as well as among cancer survivors. We see that there's a higher incidence of preventable cancers. I'll speak to that a little more in detail, but we see that things like lung cancer, where roughly 80–90% of those cancers are attributable to smoking. Not every lung cancer, but most are. There's an opportunity to reduce that with smoking cessation or smoking prevention interventions. We see higher rates of colorectal cancers in rural communities, and there's opportunity, of course, to prevent those, better diets with removing precancerous polyps through colonoscopy, those kinds of things, as well as HPV related cancers through vaccination. We see, however, there's lower screening rates for particularly colorectal cancer in rural communities, and ultimately this leads to higher mortality rates. And we also know that in general, this is general less access to primary care, cancer specialists, and NCI designated cancer centers among rural populations. So getting that initial education or prevention or screening through primary care is getting more challenging for rural, as well as, if they are diagnosed with cancer, to get, maybe having to travel further to get the necessary treatment, or to be engaged in or receive, increasingly more specialized care, like at NCI designated cancer centers, or access to clinical trials, or those kinds of things. And there's some studies, although this is a little bit mixed, that rural populations are a little less likely to receive guideline concordant treatment. So this is just giving us the kind of thumbnail sketch of the disparities that are faced. But we also know there's, I don't never want this to be a doom and gloom kind of slide. This is just partly our reality, but partly our opportunity to address these things, knowing that, while there are higher incidences of preventable cancers, that provides great opportunity to address those things in rural communities. And there's a lot of strengths in rural communities with the tight-knit nature, with the collaborative nature of rural communities to really address these, and as well as thinking on state levels with comprehensive cancer control planning processes is really a great opportunity to collaborate with rural communities to move the needle forward. To speak a little bit more specifically to some of those preventable cancers, this is some work that I'd done with some colleagues a few years ago, and actually worked this summer with some students to update this analysis, but know that we've found very similar findings with that. But we see that these preventable cancers, lung cancer, colorectal cancer, cervical cancer, as well as HPV associated, that includes cervical cancer, and tobacco associated, which includes lung cancer, those are consistently higher in rural populations. And while we see that for most of these, they are decreasing in rural populations, they are decreasing at a slower rate compared to the urban counterparts. So for lung cancer and colorectal cancer and cervical cancer, we see those decreases, albeit slower. However, we see increases in HPV-associated cancers, and our updated analysis has shown this is now increasing also for urban populations, where it was more steady before, but we're still seeing that higher rate in rural. So anyway, a lot of opportunities to address these disparities in these populations. So what is this? Tying this to this idea of comprehensive cancer control planning. So a lot of the work that I'm going to discuss today, and I've discussed in previous webinars that I've had the chance to collaborate with the Geographic Health Equity Alliance on, and over the past year and a half, have really focused or sprung out of this particular advisory report from the National Advisory Committee on Rural Health and Human Services. They're an advisory committee that assesses rural health and human service needs on a variety of topics. And in August of 2019, they released one on cancer prevention and control. And one of their recommendations I have noted here is for the CDC to require states, territories, and tribes or tribal organizations to assess mortality differences, rural urban mortality differences as part of their cancer control plans, and to develop and implement rural focus goals, objectives, strategies, and participation in areas with high rural cancer mortality rates. So I think this is a important recommendation, and regardless of the CDC's particular action, this is just something that can be done. But there hadn't, when they provided this recommendation, there hadn't been like an assessment of what does this look like among states currently. How are they engaging rural populations? How are these plans in developing rural focused goals, objectives, and strategies? And so this is something that I had the chance to collaborate with some other faculty members and students to take a look at. So this is something that analysis that we did kind of in the early phases of the pandemic, and I really excited that this was led. So the first and second author of this paper that was published in the CDC Journal Preventing Chronic Disease was two students, one at the University of South Carolina and one at the University of Iowa, who really led this work in collaboration with myself and a couple other faculty members. We did a content analysis of all the plans on the CDC's website as of January 2020. So taking a look at, the CDC puts all of each state, each tribal organization that does this, each territory puts their plans publicly available on the CDC's website. So we, at that snapshot in time, downloaded those and took a closer look at those. And this is, we did also look at territories and tribal organizations, but I'm focusing just very briefly here on the ones we did on states. And we found that most, over 2/3 of states, had some rural elements included. A good portion of these had, a description of the cancer disparities around rural in their state. Some had specific data, but we see, there's a little bit less on a, rural specific goal, objective or strategy. We do see that about a third of those had a rural strategy or objective, but which is good. There's an opportunity for growth in that. And so we wanted to get a better sense. Then kind of the next question then that this invites is, how have state comprehensive cancer control programs engaged rural partners and included rural perspectives in the planning process? So we know that, in order for goals, objectives, or strategies to have that rural lens or, rural relevance, we need to have those rural perspectives. So we wanted to take a closer look at that and know that, doing a content analysis of all these documents, only gives us, helps us answer some question, doesn't help us answer every question, like how have these programs engaged rural partners. And we could take a look at, their list of their committees or people involved in the process, but we don't know exactly where everybody's from or those kinds of things. And this really gave us an opportunity to have some conversations with those folks engaged in the state comprehensive cancer control planning process. And so that's something that we did, and we published this earlier in Cancer Causes and Control. This is just a screenshot of the abstract. And this, as you can see with the number of authors, and this was a big team effort in doing these 30 interviews across the United States and analyzing and summarizing these. And that's what I will largely speak to today. So just a little bit of background on this. We did 30 interviews with state comprehensive cancer control leaders between May and August of 2021 to assess how they engaged rural partners and addressed rural priorities in their plans. So largely these are state comprehensive cancer control program directors. There are a few interviews that were with other folks who were in similar roles, maybe leading a coalition or those kinds of things, but really aimed at trying to have these discussions with the program directors of the state comprehensive cancer control programs within 30 of the states. So our goal was to identify states for inclusion using a stratified random sample. stratifying by both rurality and region, because we wanted to really get a sense of how states that are, have a higher proportion of rural populations versus a quote unquote lower. And this is where we used, the average percent of the population living in rural counties, and in those who are, in the higher rural states had over 20.5% of the population living in rural, and lower is less than 20.5. And then we also wanted to get some representation across regions, so we also kind of did a stratification across regions, and then randomly selected based upon those. And to do 30 interviews, we ultimately had to initially reach out to 39 states before we got to that 30, because just some were, for a variety of reasons, unable to do it. Obviously, you're working in public health in spring, summer of 2021, you had a lot of other things on your plate. Even working in the cancer space, the pandemic threw a lot of things for a loop. So we totally understood that took a little bit of time to get to that 30, and we're really grateful for anybody's participation, everybody's work in this area. So ultimately, our work group members interviewed those 30 leaders, following a semi-structured interview guide focused on rural inclusion in comprehensive cancer plans across these 5 different areas. The paper itself focused on summarizing the rural inclusion in the development, as well as strategies around future plans. So those are the areas in bold. We also asked about, the content of the plans. That is something we were kind of able to assess with the content analysis itself, but we also wanted to see going forward, because we know that there's, that was in 2020, and states are, updating these at a regular basis, that we want to get a little bit better sense. I'm not covering that today, but that's another piece we asked. I'm also bringing in, even though this isn't covered in the paper, we asked a little bit about rural inclusion in the implementation and evaluation of the comprehensive cancer control plan. So we'll be sharing that as well. So we audio recorded these interviews. These were transcribed verbatim and analyzed qualitative analysis to identify themes, sub-themes, and illustrative quotes. And I'll be sharing some of those here today as a starting place. All right. So just to give a little bit of an overview of characteristics of these. So we had a little bit more than half were from the high rural states, and we had proportionate representation across the regions, with 57% being from the South or Midwest. Most of those we talked to were affiliated with the Comprehensive Cancer Control Program within their states. Again, that's who we were aiming for, but ultimately, sometimes that ended up being someone else we spoke to on a couple of occasions. And the plurality had 3 to 5 years of experience in their current role. And so that varied a little bit, but the highest, when we categorize those by years of experience, the highest percent being in those who had 3 to 5 years in their current role, just to give a little bit of overview of who we spoke to with these interviews. So the identified themes, and this is primarily from the described in the paper. Again, I'll also speak to the role, engagement of rural for evaluation and implementation purposes. But the key things that we kind of coalesced around with identifying through these interviews is the barriers to prioritizing rural populations, as well as successful strategies that were used to include a rural focus, and strategies that were either suggested or planned by the interviewees in future processes. So recognizing that you can see what works, but also what you plan to do to help improve upon what's already being done. So some barriers to rural inclusion that we identified, outline a few of those here, is the belief that these plans should be broad and general. So, noting that, for example, the plan doesn't set any specific priorities for addressing specific disparities, is just a general overview. So I think that response is just this idea that, okay, we don't necessarily see to target certain population groups. We want to make it, broadly relevant for our whole state. one of the other barriers was just the challenges of defining rural populations. And, you see this here, if you look at HRSA, the Health Resources and Service Administration, some are considered rural, different, go by a state definition of rural, there's, a higher percentage of counties that are rural. So I think that is a very common, as someone in the rural health research space, that is something we run into quite a bit. You ask 10 people to define rural, you get 15 different definitions. So we recognize that that can be a challenge in how do we define it before we go forward and make sure we include it. So the geographic distance, if you have in-person events for comprehensive cancer control planning processes, that can be more prohibitive for rural populations in particular, as well as those in urban areas, if requiring an overnight stay, and depending on what their role was with their employer, it might not have been something that was supported for their participation or having to use their own time or those kinds of things. So that can become a barrier, particularly I think for rural populations. Sorry about that. Yeah, so those are barriers to rural inclusion. Sorry, I'm going to remember what order I put these in. So that's in the development of the plan. I think it's also important to think about involving and actually implementing the plan and evaluating the plan. Those are key pieces of this. Those of you working this know this well, pardon me. When we think about comprehensive cancer control planning processes and the funding available to that from, a federal sense and those grants from the CDC, there's limited funds, available federally for this work. So implementing and evaluating becomes even more of there's greater barriers in general for that. So we recognize that as well, but want to speak to the implementation evaluation piece in addition to the development piece, because we can develop a plan, but if we don't have the opportunity or the ability to implement that, and it's just another document that we have that it's printed out and sits on a shelf or sits on a website as a link, and we want it to go beyond that, of course. So what we found with implementation is that there is varying levels of rural involvement in the implementation process. So we see that there were some specific ways, though, that rural was involved in this. One was through work group and coalition involvement. So that's an important way to get rural folks involved, is to engage them in whatever your structure is for your program or your coalition, and have them involved. So we see how that's with health department leaders, with nonprofit organizations and others, to get actively involved. There may be specific health issues in which rural individuals were involved, or rural groups. So, for example, one state here found that the western part of our state, was very focused on survivorship, and made that western part of the state had a more rural, being more rural. And so that work group was very, very active, and developed a great document for survivors around dimensions of wellness, and they were able to get people engaged. So that's some ways that we see that rural folks were involved in the implementation of a plan. What are some of the barriers, though? We see some barriers that emerge from not just the planning process, but also the implementation process, and lack of resources. We see rural communities with finances, and less, sometimes not having that connection with a large university that has resources, especially for healthcare, that can be a challenge to implementing some of those goals, objectives, and strategies. And having rural communities and folks engaged in that. Lack of collaboration. Noting here just dynamics in workforce or turnover that can occur, that people having to jump into a new role, and maybe not having as much opportunity for collaboration. And I think that's something that of course it looks like there'll be greater collaboration going forward with this particular quote. But that can be something that prevents implementation if there's not that collaboration at the state level with those rural communities. So again, this just kind of speaks to some of the other involvement as far as other barriers, lack of resources, many responsibilities. We just know that's true of many people in public health. But I think especially rural folks, have a lot of plates spinning, a lot of things on their plate, lack of collaboration. So a couple of these, I highlighted some quotes from these, but also political factors. We run into that where, let's see, so I neglected to put this quote in there, but the political factors being a key one, where there's the quote around this specifically pointed to some rural populations, they didn't have, they had pushback on accepting any kind of state level public health funding, for example, or other sources of public health funding. So that, being able to implement some of those goals, objectives, and strategies were more challenging because of the political nature of public health sometimes. So I want to speak to that. So shifting gears and talking about evaluating the plan additionally. So there's several ways that were brought up as far as involvement in plan evaluation. Some plans have an evaluation committee. So recruiting and including rural representatives on the evaluation committee is a key way that this was done among some states. Having focus groups, evaluation focus group designed specifically for rural participants was another way this was done. Having tribal partners involved in evaluation is another key element. We think about some states with a larger indigenous or tribal organization population that can be a very key one. Some states, they have opportunities for implementation grants. And so those rural stakeholders who receive those grants may have their own individual evaluation process that shows how they specifically have implemented or evaluated the implementation of the plan. Just having those plan stakeholders being in and serving rural populations, that kind of ties in again to having folks involved in focus groups or committees or those kinds of things. It's really important. So there was one state where the contracted evaluator was from a rural part of the state. So that's another way that we see this having this rural involvement in evaluation. So one thing that has emerged throughout kind of our work in this area is this perception of rural. So some states are, as I noted, are very rural in nature. And so if you're doing a plan in a place that is very rural, implicitly, anything you do is going to be rural. So there may not be this sense of, oh, we're really focusing on rural because if your whole state is largely rural, then that kind of becomes implicit. So that's something that emerged, and what we found is that maybe people weren't necessarily thinking about, oh, we're going to focus on rural or not because the state is very rural. And then another note is including data from rural areas in summaries and analyses and those kinds of things. So these are some examples in the evaluation plan process. So some barriers. Again, this is going to kind of mirror to an extent some of the implementation barriers, but also have some unique ones. So I just have one quote here, is that, one example is there was not outside involvement in the evaluation process. The evaluation is done at the state level with the health department. So there wasn't necessarily that. So that was one barrier. It's just more of a way, the process of doing the evaluation. So it wasn't necessarily specific to, excluding rural, but just that element there. Geographic distance, again, being a challenge to being involved, not having that relationship with rural stakeholders, noting that the evaluation metrics may not be relevant to rural areas that experience immediate needs. So thinking about, the immediate needs versus the long-term strategies and goals and objectives that may be, I don't say misaligned with the needs of rural communities, but thinking about the balance of immediate versus long-term and how we evaluate those. And then COVID, we know that hit everywhere very hard, but there are certain times along, that progression of COVID, as it got further along, it hit rural areas particularly hard and made it difficult to enable rural partners to get involved, because they were obviously, from public health or healthcare perspective, were focused very much on addressing that very pressing, immediate, acute, and very hard-hitting need in their communities. So those were some barriers. So that's a little bit on how barriers to and how people have engaged rural communities in the planning, implementation, and evaluation process. Just to give that a little bit of a background there. And now I want to talk a little bit about going forward. What are some suggested or planned strategies? What are some ways to move this forward? So we could see this with some of the barriers, and now addressing, we're going to see some alignment here, I guess, with some of the barriers that were identified and what are some of the strategies to engage rural. So you can see these first two are somewhat similar, but I think distinct in their own ways as well. One is just simply building those relationships with rural communities. One participant said we can't develop another cancer plan that hasn't been vetted by not solely academic stakeholders, but by people in the communities that we're trying to affect. So that's really building those relationships, getting those perspectives, and that ties into actively engaging rural partners in the plan development. So thinking about new board members, if a lot of this where you might have state level comprehensive cancer control program directors they work very closely, of course, with state coalition oftentimes. And so maybe having that state coalition make sure that there are rural representation in the board, geographic diversity in the board, and that can help kind of ensure that you have those relationships with rural communities as well. So those can go hand in hand. That also ties into developing better understanding of the rural needs, and that they're going to know what they need. And so having those people at the table, whether that is vetting the plan itself, whether that's being on a coalition board or other things, having that engagement is going to lead to that better understanding of the rural needs in the state. And then also considering the resources needed by rural populations, whether that's an extensive list, noting that some rural stakeholders have created lists of transportation resources that are ADA accessible, those kinds of things, and understanding those needs that might be specific to rural populations. Some other strategies to note is, again, with this idea of these are stretched or planned. These are some that have been used. You're going to see some overlap here as well. So collaborating with healthcare systems in rural areas. So thinking about the different types of rural stakeholders and folks that are needed to be engaged. It's, thinking communities, but thinking about within those communities, healthcare systems, smaller cancer centers that are more rural or that serve rural communities can be an important way. Rural constituents. So thinking about not just the board, thinking about work groups, however your comprehensive, program, your coalitions are developed, whatever the hierarchy, the org structure is, getting rural folks involved in those. Leveraging rural community academic partnerships. So that can be really important if those are available, or those are already active in your states. To do that can be a really important thing. And as you noted, thinking of states where there are more indigenous populations or tribal organizations within those, seeking Native Nation involvement, making sure that their voices at the table, making sure that's well represented, thinking of, we think of, that Native Indigenous populations tend to largely live in rural areas, that is going to be really important to make sure that that is included. While some tribal organizations create their own plans themselves, if they are living or working, they are within that state, there's going to be certainly a role to include them in state plans as well. So this is kind of summarizing some of the things that I've already said with strategies in current plans, strategies suggested for future plans, but thinking specifically about examples of those. So healthcare systems in rural regions. This gives a little bit of a more specificity with those examples. So recruiting rural community members through collaborations with community health centers. We know 1 in 5 rural people get their primary care from a community health center, FQHC. Rural health clinics are extensively available, are key other sources of primary care in rural areas. There's more than 5,000 rural health clinics throughout the country. Connecting with those can be another way. Local health departments and Native Nation clinics are really important. So actively recruiting rural constituents, maybe that requires, regional cancer coalitions in addition to the state level, planning work groups, those kinds of things. An academic researcher advisory board, again, to leverage those community academic partnerships, Native Nation members on cancer coalitions. Again, that is another way to engage both healthcare systems and well as Native Nation involvement, thinking about those interactions. So those are things that have been done currently. Some additional ways, I guess, again, these tie together because some states have been doing this all along, and some are looking for new ways to better engage rural populations. So establish new relationships with rural health systems and community organizations is really important as well. Seeking and inviting more rural engagement. So this can be stakeholder mapping, extra effort to engage those who have not been as engaged before are really key ways as well. Trying to understand the rural needs more completely. So that's, making sure there's a broad range of stakeholders at different levels to conduct community needs assessments, as well as using and leveraging secondary data to identify those gaps. And I'll point to some previous webinars we've done on that topic as well, if you're not familiar with those, and that can be a way to really look at that. And again, considering resources, that, not just looking at the needs of the community, but considering the community assets and the social determinants of health factors, seeing what assets can be leveraged, but also what needs need to be addressed to be able to fully engage and include rural populations in this process, to help address those disparities that I noted at the beginning and make those improvements. So the key takeaway, again, just summarizing what I've already shared, is focus on relationship building and working through established partnerships are really key. I think these are all things, we're familiar with. That's a key element of public health in general, are building those relationships, working together through partnerships. I think recognizing that there can be unique approaches that are necessary when, we might be state public health departments in a urban area trying to make sure we reach our rural populations throughout our states. And so that, building those relationships, working through established partnerships, then kind of leads to this ability to be able to identify and seek engagement from those who have not previously been represented in the planning process. So when you have those relationships, you establish that trust and work with those partnerships you already have, you're maybe better able to identify and engage those who haven't been involved before. And that then leads, of course, to better understanding about the gaps, assets, and resources within your state, because you have better engaged those folks who haven't been at the table before. And then focus on identifying and building resources needed to meet rural health needs. Resources, of course, is the key challenge in public health, regardless if it's urban, rural, state level, local, et cetera. But, working on identifying and building those resources to meet those needs is really key. So if there are state level opportunities to do that, whether there are federal grants, HRSA or USDA has a lot of has several network building grant opportunities for, from a rural health perspective, can this be leveraged to, those sources as well as others to be leveraged to meet those needs. So one thing I want to note is I had the screenshot of the paper earlier. This was a big team effort. And so we had folks from our Rural Cancer Work Group from numerous, institutions that are part of the CPCRN, University of North Carolina, Emory University, University of Arizona, University of South Carolina, University of Washington, some folks who are affiliated, whose institutions were part of the CPCRN, but were affiliated individually from Drexel, University of University of New Mexico, University of Colorado. I apologize. They're part of the CPCRN, and Moffitt Cancer Institute, as well as some folks, the CHI core team. These are folks at a center at the University of North Carolina who did much of the analysis of our interview transcripts that led to this. So we're going to certainly identify those folks who are key in the analysis of these interviews. A couple of things I want to share. So the last year and a half, I've had the opportunity to talk about this general overall topic of rural inclusion and comprehensive cancer control planning processes. And all of those webinars are available on the Geographic Health Equity Alliance. I have them all linked here, and I'll be sure to get the slides passed on, so those can be shared with you all directly or on the Geographic Health Equity Alliance website. These are all linked here. We did a webinar on describing rural communities. So that idea, identified within these interviews is having that data on rural communities. And so the webinar really focused on what data are available. Secondary data can you use to define and describe your rural populations, building rural focused partnerships. So we had a webinar with a couple of folks from here in Iowa and Illinois, and some of the ways that rural focused partnerships have been involved have occurred in the comprehensive cancer control planning process. And you can see a little bit more on that through those from those perspectives, whether it's having rural cancer focused work groups within a coalition, having the evaluation partner do some particular rural outreach and engagement. So that's an example. And then talking through how to set rural focused goals and strategies in the planning process, recognizing that the most recent cancer planning or program grant from the CDC really emphasizes this idea of called SMARTY goals. So we might be more familiar with SMART goals, specific, measurable, attainable, etc. And this, SMARTY goals adds inclusion and equity to that set of criteria in developing goals. And that's going to be really important when we think about rural inclusion and addressing inequities and disparities in cancer for rural populations. So that's there. And then also identifying and implementing evidence-based strategies and comprehensive cancer control planning. So that's a webinar that has some folks from South Carolina, Colorado, and some work done in Kentucky around cancer screening efforts in rural populations that have been tied to some of the strategies, evidence-based strategies. So just want to make you aware of those being additional resources in this general topic area. Also linked to the journal article that I have summarized today. And I'll also share, we have kind of a one-pager summarizing what we found as well that I will share. It's not linked on our website or CPCRN website yet, but I will make sure that's available and shared with you all as well. So with that, I want to thank everybody for their attention and participation today. We'll open up for questions in a moment, but I also will share here my email address if anybody has questions later on, as well as the link to our Cancer Prevention Control Research Network and some of the resources we have available for communities. Feel free to check that out as well. And with that, we'll wrap up here and open it up for questions that folks may have. So thank you very much. And I think those can go through the Q&A, I believe, and I'll keep an eye on that to see if there's anything added there. Okay, yes, thank you. So I see one here. What lessons about rural equity do you think we learned during the pandemic? Overall, COVID vaccination is much lower in rural, so I'm curious as what you think went wrong in that effort. That's a really important question. And I think we need to try to learn what we can from the COVID vaccination effort in rural populations, both for COVID, I should say, not just for COVID, but for routine childhood vaccines, for HPV vaccines, thinking about cancer-related vaccinations. We know that it is much lower in rural. And so I think there's several things that we need to learn. And a couple of things are, making sure, public health communication being a really key one, communicating, you know, and tailoring promotional efforts or, educational efforts around vaccines to rural populations. I know some folks here at the University of Iowa had done that with rural communities here in Iowa, making sure that kind of having, interviewing and having conversations with rural folks as to what's going to, make people get vaccinated. And so I think also being very, very clear and transparent and honest about about the vaccines, and it's going to be really important. I think one thing prior to the pandemic that has always been effective, has been proven particularly effective in rural communities, is having champions for any kind of public health initiative. So you would think about it in the cancer space, that having somebody who's really respected in the community doing outreach or ads or communication around getting colorectal cancer screening or mammography or other things can really play a key role. And so I think that's also important when we think about COVID. So I think I don't have a really clear-cut, concise answer, but I think, making, I think communication is important. I think accessibility is important. I think, those are some key things. I do want to note as well, kind of on the flip side, I noted in what I shared already on COVID playing, a factor in being able to have rural communities engaged in comprehensive cancer control planning processes. And we found that, that distance can be a barrier. We also found some kind of mixed findings around moving things more virtually. So we found a little bit that, obviously broadband access in rural communities made it challenging to participate in virtual events sometimes, but also that, having those virtual events removed that geographic barrier. And everybody participating virtually can mean that everybody can be engaged. So I think, that's a positive lesson maybe we can learn from the pandemic. I know that, virtual is not perfect, but it may remove that transportation or that geographic barrier. So yeah, I know that's not a full, I wish I had the answer about this. I know there's some folks at St. Jude's HPV vaccination program that are really trying to focus on this in rural areas. So I think, also working through obviously clinicians being recommenders, I also know that as a key one. So making sure that clinicians in rural areas are on board and informed and have the appropriate information around COVID vaccines or any kind of vaccine to be able to recommend that to their patients is really, really key. And I think that'll be increasingly important going forward, especially with just the barrage of misinformation and accurate information and varying levels of nuanced information that we're all faced with to make heads or tails of that. Okay. So thank you for that question. And there's another one about more networking opportunities and grants available for those efforts. So sure. So I'll point to a couple of resources. One is, if you aren't familiar with the Rural Health Information Hub, I'd really recommend accessing that website. They have a weekly newsletter that also includes a lot of information about grants and other things available, more for developing networks or sustaining networks. And a lot of those come through the Health Resource and Service Administration, or HRSA, or the USDA. Both of those organizations have rural health related network development grants. So I know, I previously worked in Southern Illinois, and there was a group called the Healthy Southern Illinois Delta Network, and that was a network of multiple state coalitions in the southernmost 16 counties in Illinois, very rural area, and they initiated that network through one of those USDA grants, and they've been able to sustain that for years just by being able to work together. And the Rural Health Information Hub shares those in addition to many others. They do a really good job of weekly sending out those emails, and they have those also by state on their website. So in your state, you might, they might share, oh, there's this, opportunity for this grant, For example, in Iowa and a few other states, Telegen is a great grant opportunity for those kinds of networks or collaboration. I think it's, I don't remember all the states, Iowa, Illinois, Colorado, and Oklahoma, or something like that. But there's different opportunities for different states. I would point to that as well as also, with the HRSA side, the Federal Office of Rural Health Policy has a weekly newsletter or listserv that they send out similar kinds of information that would have the more HRSA related grants and other opportunities that are rural relevant. So I can, when I share the slides, I can maybe share some of those links or information, make a note to myself, and those can get disseminated to those who participated. So thank you for that. That's a important question. A quick note here for the next question, address the next question. How did language and literacy needs play into rural provision of services? That's a really important question. That's not something that we particularly saw spring up and as far as engaging or including rural populations in the comprehensive cancer control planning process, but that definitely is something that is really important for rural communities in both the overall literacy respect and the language respect. We know that in general, health literacy particular it tends to be a little lower in rural populations, and we need, as far as non-English language services, those are less accessible in rural populations. So those are things that I think are really important to address, especially when we have growth in different populations in rural areas. So that can be a barrier. I know that there are translation services available in some places, whether that is a in-person translator or some kind of services that are available within hospitals, but that is something that is increasingly important in addressing those needs. But that's not something that we immediately sprung up out of our conversations with these program directors in this. But of course, those are really key to make sure that people understand the service, the healthcare services, the care that they're receiving, and are able to act on that. That's certainly important. Are there other questions? Give it another minute or two. And then, of course, feel free. I saw my email address up here on the screen, so feel free if something emerges later on. I am happy to share that with you. Try to address your questions or point you to resources. And like I said, I will be sharing the slides, the one pager we have on our interviews. I'll also share a couple of those email lists or links that might be helpful, particularly on the network grants and those kinds of resources for folks. there's nothing else, I'll turn it over to Abby. I know you have share on the evaluation side. So thank you all very much for your questions and attention and everything else. I really appreciate the engagement and participation.
As we conclude the webinar, we wanted to give a big thanks to Dr. Zahn for her work and insights, and we wanted to thank the webinar attendees for your participation. Stay tuned for the post-webinar email that will have a link to the evaluation survey, or you can scan the QR code here. We kindly ask that you take a moment to complete the evaluation survey. You can find the recordings from past webinars on the GEO website as well. So thank you again for joining us, and we hope you have a wonderful rest of your day.